Greetings, everyone. Osio Tahija. Osta. My name is John Lowe, and I'm a Native American. I'm a Cherokee tribal member with also Creek and Lenape tribal heritage. I currently am the professor and Joseph Blade Centennial Memorial Professorship Chair at the University of Texas at Austin School of Nursing. And I'm also the founding director of a new center that is being developed at our school. And this is titled the Center for Native American and Indigenous Health Research. And this is going to be nurse focused and Indigenous nurse led. And so we're really excited about this opportunity that we have to be able to do this work. Today, we are going to share with you a number of our colleagues, my colleagues and my friends and across the world, and they are Indigenous nurse leaders. And so they will be sharing with you their slides and their presentations and sharing with you about their lives and their careers and the work that they do. Very impressive. It's been such an honor to be connected with this group. And this group has formed a coalition and that we represent the various parts of the world. And so you'll be hearing who they are and where they're from and who they represent. One person cannot join us today, but she will be joining us for the panel discussion, and that's Dr. Lisa Bearskin, who is doing tremendous work in Canada, and she is First Nations, and she is leading the Indigenous nurse work there. And so we look forward to having her join us for the panel discussion. So first I would like to do acknowledgements. I'd like to acknowledge the people of the land that we find ourselves on. And there are many throughout the whole United States, in particular, wherever you may find yourselves today in whatever land, I would encourage you to explore and discover who those original peoples were. And we're talking about the Indigenous peoples. And it's good to stop for a minute, pay our respects, because none of us would be here if it weren't for the sacrifices that the original people made, and we would not be able to even gather today. So we really do want to pay our respects to those who came before us and those who are present and those who are yet to come. In particular, I want to pay my respects to two elders of mine who have been behind me and supported me throughout my life and career as an Indigenous nurse leader. And these are two tribal chiefs. And they have been so important in my life. And so much of what I've been able to do is because of these two. So I, again, am honored to have had their mentorship, their love, their caring, nurturing, and guidance. So when we think about health disparities and inequities among Native American people, we think about why that is and where did that really originate. And for us, we know that it really originates in the dispossession that occurred with us. And this has been the dispossession of land, lives, culture. It really equates to is a genocide experience. So our trauma, what we refer often to as our historical trauma, is really steeped within the genocide experience that we have experienced and we continue to experience, because the trauma is still perpetuated, still passed from one generation to the next, and is still with us today. And so this is why we are so passionate and we feel called and in our purpose to be able to address these issues. For my work, I was guided by my elders and those who were giving me guidance to really begin to look at our youth, and that our youth really must be our focus. And so there are three questions we ask our youth: who are you, where are you, and where are you going? This has helped to guide our work, particularly in the area of substance use and in associated risk behaviors among our youth. We don't know that much about our younger youth. The data is not real prevalent, but we have been able to do some of that work, and we are doing more of it. And we know that around age 10 and 11, our youngsters within Native American cultures and communities usually initiate some sort of substances. And this is earlier than most other populations as far as age-wise. What I was able to do, again, with my team and the help of my elders, we developed what's called the Talking Circle intervention, which is an intervention that addresses substance use, but takes a different approach than a lot of the other programs that are available that are often forced among Native American youth, and especially in schools. Ours is a strengths-based, cultural-based intervention where we have the youth really focus on who they are and the values and the traditions that were once demonized, and in many cases still are demonized by the dominant population and culture and mainstream, but we have them look at it how sacred it is and how sacred they are because they were created by a sacred spirit. The Talking Circle intervention is considered to be the first manualized, meaning we developed a manual to go along with the sessions that are used at each session. And we have developed a way for the manual to be individualized per tribal group, per culture, meaning each culture and each tribe can make it their own. They can use their own language. They can use their own traditions and values and make it really relevant to their particular culture. This intervention has received many awards, and one is that it has been evaluated and examined by the United States Department of Justice Office of Programs as an evidence-based program for the well-being of youth, and especially Native American and Indigenous youth. Has received the American Academy of Nursing Edge Runners Award, and most recently, the National Academies of Sciences, Engineering, and Medicine included it in their report regarding the future of nursing 2020 to 2030 as one of their featured programs that is being used to address health inequities today. So we've done many studies looking at the impact and effectiveness of the Talking Circle. One of our most recent was we tested the Talking Circle virtually. It was a 5-year study. Many of our studies have been funded by the National Institutes of Health. We've conducted randomized trials so that we know and we have the evidence that this cultural-based intervention works so much better than the other programs that are available. This is guided and based upon a framework, a theoretical framework and model, and it's called the Native Reliance Model and Framework. And this is a framework that came out of some of my earlier work and has evolved over time. And it's great because so many of the theoretical frameworks that we are often either forced to use or recommended to use in the academy are not really relevant to who we are. So it was really great to have been able to develop this framework to use within our culture. In addition to the framework and model, we were able to develop a questionnaire, and that has great test reliability. And this questionnaire has really been useful in the studies that we have conducted because it gives us an insight and the evidence that our intervention is impacting the cultural identity of those youth participants that go through the intervention. Another framework that I was able to be a part of developing is called the Conceptual Framework of Nursing in the Native American Culture. And I just mentioned it because all of these conceptual frameworks that are really developed and derived from within the culture are so necessary. And, if nursing, we just don't have that many that are really pertinent or that have been developed from non-mainstream. So these have been very useful in guiding and in the development of curriculum for nurses and how to give care to Native American populations and communities. So it's been a real honor to see this move forward and to see it continue to be used. Another model that we were able to use that came out of some of our work is about cultural tailoring. And we developed this model to guide us in how to do the tailoring of our frameworks and the tailoring of our interventions. And we go through this process, and it takes a different process than a linear process that many academics use when tailoring models and interventions to use for other people groups. So this has been, again, another very pertinent, very relevant to who we are and within our culture. So in 2017, I had the honor of developing and hosting the first Indigenous Nursing Research for Health Equity gathering, the summit we had when I was still in Florida. And this was the first gathering of Indigenous nurse researchers from all over the world. And it was such an honor. And this is where our group today really coalesced and we became even closer. We have now become more like a family. And this really demonstrated the very valuable work that we as Indigenous nurse leaders are doing and need to do. And so we are continuing this effort. The second one, it was conducted in Australia, and Dr. Odette Best, who will be sharing with us today, did a great job in leading this and hosting it. And it was a tremendous event. And we are continuing this work. Our next one we have planned to do will be in Panama with Dr. Eugenia Miller, who is with us today also. And we are planning an in-person event every 2 years. And of course, COVID had us sit out a year, but please look for the announcement of the next one. And it will be in Panama. And we will continue to do these and build this coalition and the work and support that Indigenous nurse leaders are doing. And so with that, I will close and I'll say thank you, Adam.
Good morning, everybody. It's a privilege for me to be here today. It's very early here in Australia, and it's in the middle of winter, so hence why I'm rugged up at the moment. But I feel very privileged to be speaking today amongst the group of people that I am. I am Indigenous Australian, and what we do at times of meeting new people is we always acknowledge country. An acknowledgement of country for us in Australia means that we acknowledge the elders of all the lands that we are on today. And we are on so many diverse lands for today's presentations, and I feel really privileged to be amongst them. And that crosses continents and oceans and countries and nations. So I acknowledge your elders. I acknowledge your elders past, your present and your emerging elders. I also too need to acknowledge my own elders in presenting the work today. More importantly, I acknowledge my elder, my grandmother, who we think is approximately 105. And her name is Mukan, which in her language means old woman, old tongue. So I acknowledge my grandmother and the blood that runs through me from her. Thank you very much for inviting me to participate in today's presentation. I'm an historian. But apart from being an historian, I am a registered nurse. And in Australia, we had hospital-based training programs up until the early 90s. So I am a hospital-trained registered nurse of 3 years. And I currently sit as a professor in the School of Nursing at the University of Southern Queensland in Australia. What we always do first is what is called Japal Naganya. So Japal Naganya, in my grandmother's language, translates to Song of Me. When we present our work as Indigenous Australians, we always do what is called basically a Song of Me. And so I would like to offer the Song of Me to all the participants today. I'm a Wakaun clan member of the Gurungaring Nation through my maternal grandmother, my elder that I just acknowledged, and hold a Bontamora bloodline through my maternal grandfather, her husband, of many, many years. I have intricate ties to Kumamberi-Yugambeh people, which is through my paternal grandmother, and I have significant ties to Warrabinda Mission in central Queensland through my maternal grandmother and also grandfather. Both were removed to this mission in the 1920s in Australia. I also have foundational songlines and cultural ties to what is commonly called the Gold Coast in English language, but the traditional name for it is Kumamberi, and South Stradbroke, which the traditional name for that is Minjerribah. These are the lands of my paternal grandmother. I am also a professor of nursing and the associate head in the School for Indigenous Research and Community Engagement in Queensland, Australia. So I'm going to talk about being a historian, being a registered nurse and one who does historian work of Aboriginal or Indigenous nurses here in Australia. My own PhD journey was actually called Yakdullijan, and I looked at the stories of Aboriginal registered nurses in Queensland from 1950 until 2005. The word Yakdullijan is again my grandmother's language, and it means learning in a good way, but learning that can be at times hard or challenging or difficult, but it's still learning in a good way. So from my PhD studies, this kind of like started the whole trajectory, I suppose, for me to become an historian. Just to give you a really brief background, like many countries that were invaded by the English, Australia has had, well, what is now known as Australia, has had a troubled, problematic, racialised history with coloniser and Indigenous nationhood sovereignty within Australia. We have a life expectancy as a difference within Australia of about approximately 12 years between Indigenous and non-Indigenous people. Racism is real in Australia. It is felt every day in Australia. It rules a lot of contexts within Australian healthcare, which is incredibly problematic. So just really briefly, these are kind of like what are called the eras of administration for Indigenous Australians. So why I wanted to present this was to give you a context of where a lot of my research now sits, and it's within the protectionist and segregation era. So the protectionist and segregation era started approximately in the 1870s here in Australia, and it was a little bit different across all states and territories in Australia. Where I'm from in Queensland, we were the first state to actually legislate segregation. And our legislation was actually the template for South African apartheid, and it was utilised in South Africa to set up the apartheid laws there. So we have a deeply, deeply troubled and problematic history of race relations in Australia that continue to this day. I particularly am really interested in this era of protection and segregation because in the 1890s in Australia, when Queensland actually introduced our legislation of segregation for Indigenous people, essentially two things were occurring that kind of like ran parallel. One was mass removal of Indigenous people into missions and reserves right across the state and also Australia. Hence why one set of my grandparents ended up on Warrabinda Mission in central Queensland, where they were behind 8-foot barbed wire razor fences. They were not allowed to speak language. Western food was introduced to them. Our disease processes absolutely skyrocketed. And these were incredibly detrimental times for us as Indigenous people. And this is in our DNA memory, it's in our cell memory. And my grandmother was the very first dormitory girl of Warrabinda Mission, and she remembers her removal from her traditional lands in 1927. So her stories of this removal is absolutely heart-wrenching and gut-wrenching, and it's not a thing of the past, because our elders like Moai Mukan are still very much alive, and these are part of the songs and storylines that are sung to us as younger generations. The other thing that happened in this era that I find particularly interesting, it was the 1890s that Western nursing started, essentially. So across Queensland, as in much of Australia, we actually had hospitals starting to train nurses in Western nursing formats or Western nursing training. And it's been believed for a very, very long time that Indigenous women didn't participate in this. And that's basically the crux of my research, is to actually start flipping some of that discourse around that. So I have been a recipient, a very grateful recipient, I might add too, of an incredibly competitive funding round in Australia through the Australian Research Council. And it was a funding round of history. So history usually gets undertaken within arts faculties through anthropology or archaeology or other historical work. However, a little old Indigenous nurse in a school of nursing was lucky enough or privileged enough to actually get a history research grant. So this has really been able to progress my work, looking at how Indigenous women in Australia have actually participated in the profession of nursing. And it has brought me such immense joy. So this is the background of the backdrop, I suppose, of the period of why I do my research in, the ability to actually able to do my research in, and I'll present to you now one brief finding so far to date. I would like to introduce you to Muriel Stanley, and let me preface some of this language that you'll find in my slides. The word black or blackfellas was used very widely during the era of invasion and initial contact when the English started colonising Australia, and it was very much the east coast of Australia that got colonised first. So Sydney, it spread inland, and then it basically went up into Queensland, where I'm from. All the English writings at that time actually called us blackfellas or blacks. So it is very much a word language that is utilised within Australian discourse around Indigenous peoples, and it's one of those nuanced differences for a lot of other Indigenous people around the world, in that we are identified as blackfellas. Like a lot of other derogatory and racist language, it is language that has actually been reclaimed by a lot of Indigenous Australians, and we actually use the word black or blackfella now with pride and as a sense of reclaiming it. So hence some of my slides, my next two slides, you'll see the word black, or I will show you what we've done with that language as well. So I'll introduce you to Muriel Stanley, who was one of the women on the missions up at very northern Queensland, and she was born on a mission called Yarrabah. And Yarrabah is about 40 kilometres outside of Cairns. So a lot of people may know that as the region where the Great Barrier Reef is. Now, Muriel was born on the mission, and she just wanted to be a nurse. That's all she ever wanted to do. And so she was born in the 1920s. So Muriel applied for a lot of hospitals in Queensland with actually the support of the superintendent of Yarrabah mission, which was really unusual for the 1920s. However, back in our days of nurse training in Queensland, you would have to provide a letter of introduction of who you were and a photo. The matron of the hospital would look at your letter of introduction that you were interested in doing your nursing, and then they would clearly look at the photo that had been sent in. Now, Muriel applied for dozens of hospitals right across Queensland, and absolutely not one hospital in Queensland would accept her because she was deemed too black. Some of that language was actually written in the letters that they wrote back, that she was Aboriginal and therefore was not suitable to be trained at this facility. And Muriel would just keep going and going and going for many, many years, just repeatedly putting in letters of interest to train at hospitals, and would just repeatedly get knocked back. What she actually did do, though, in the 1940s, was that she started to apply for hospitals within New South Wales. Now, the Acts of Administration was still going at this stage. Aboriginal people were locked up on missions and reserves. We weren't allowed out of missions and reserves unless we were indentured into forced labour on properties, or looking after white people's children, or being stockmen if you were male, and our women would become domestics. So this was a time when we were really still locked up under those terrible, terrible conditions. However, for some strange or bizarre reason, South Sydney Women's Hospital said yes to Muriel. So Muriel left Yarrabah and travelled down to Sydney by train, which actually took 2.5 to 3 days, to go down to South Sydney Women's Hospital and become an obstetrics-only nurse, so a midwife. After she was successful in getting her midwifery, she was actually what was called exempt from the Act. So that meant the government of the day would exempt her from the Act as being deemed that she could only be locked up on a mission. However, Muriel, even though she was exempt, she made it very, very clear to the superintendent that she wanted to go back to her mission of Yarrabah, and that she wanted to nurse her people, look after her people, and help her mob, basically. So she did. And Muriel has been an absolute joy to uncover her history. She is one of the many nurses that I have uncovered, but only one of the nurses that I have presented today. The other nurse worth noting, and the earliest nurse that I have been able to find in Australia who is Indigenous, is an Indigenous nurse called May Yarrowick, who trained in 1905 in Sydney. So we know that there is an entire uncovered historiography around Indigenous women and our working in the workforce. That was one woman, Muriel, who had the ability to train in a hospital. But what our racist governments also did was they provided on 3 of the missions in Queensland, Woorabinda being one of them, what was called the Native Nurses Training Scheme. So this was only for our girls who were locked up on the missions, weren't allowed out on the missions in Queensland, especially not in Woorabinda, the mission that I have intimate family ties to. It was a particularly racist mission. So they started what was called the Native Nurses Training Scheme. It ran for 2 years. It was only on 3 missions. Woorabinda mission started it, and it was exactly the same as hospital training. So the girls learnt their ward skills, they had assignments, they had exams, they were taught by the doctors, the visiting medical officers, they were taught by the matrons on the mission, the sisters on the mission, and they worked duties of morning, evening and night duty. And this was interestingly what I found in one of the reports in 1949 that was written by one of the visiting medical officers, was that he wrote that another encouraging thing is the high results obtained in the examination papers to test their knowledge of nursing subjects. And he interestingly noted that the curriculum was the same of that of the great teaching hospitals. So once these women made it through their 2-year nursing program, they weren't allowed to go anywhere. They were not recognised. They were not given a certificate of attainment. All they were used as was nurses on the mission. They were not allowed to move off the mission because they were still technically under the policies of administration of segregation and protectionism. So these have just been 2 of my early findings, and they've brought me so much joy. My grandmother remembers this training scheme as she was a young woman on Woorabinda herself, and was also offered a position in this native nursing training scheme, but my grandmother declined and said no. So in closing of my really brief talk, people often ask me why I do historiography, because it's not the groovy or the sexy research that nurses do or can lead. But for me, it's a really vital part for us to be able to push back against dominant discourse. So I undertake this work as an historian to talk back, but I also talk black to the racist discourse that identifies Aboriginal women in Australia as passive recipients of care and not as the active providers of care that we have been for 120 years. Thank you, everybody.
So, tēnā koutou katoa, greetings to you all. I bring greetings from Aotearoa, which is the Māori name or Indigenous name for New Zealand. I also would like to acknowledge all those who've gone before me and to acknowledge Odette and John for their incredible bodies of work. In my culture, it's also important to acknowledge the land that we are standing on. The papatuanuku or our whenua is what nurtures us. Acknowledge our ancestors, acknowledge the people in the room, and I guess because we're not physically in the room, acknowledge all of you out there. So just for a little context, I did my PhD in the United States, and nobody knew where New Zealand was, and they kind of had this perception that Aotearoa was this tiny little atoll in the Pacific. And so there we are in the little red circle, and right next to our Australian cousins. And but what people were always really surprised about how large New Zealand was, or Aotearoa was. And this is a picture of New Zealand sort of outlaid on a map of the United States to kind of give us some context of size. There's around 5 million people in New Zealand, and Indigenous peoples are about 17% of the population, and we're a really youthful population. So what John was talking about in terms of developing and nurturing our youth is incredibly important for Indigenous peoples in New Zealand. And I'm going to talk to you, take a really different tact from Odette, and I'm going to talk about some quant research that I'm involved with at the moment. So I've been part of the National Youth Health Youth 2000 survey series for over 20 years now. And I've led the last two waves in 2012 and 2019. And so over that 2 decades of research, we realised that we didn't have very good information about the well-being of New Zealand's young people. And in particular, my interest was around Māori young people. You don't have good information, you can't advocate, you can't change policy, you can't get funding for services. So we had this really audacious plan that we were going to do these national youth health surveys. So over the last 2 decades, we've surveyed over 36,000 high school students. And we've done that by randomly selecting schools within New Zealand and then randomly selecting the students within those schools. We use incredibly robust measures and, so that we can sort of monitor what's happening with young people's well-being. So it's been really strongly influenced about what we think are the issues for young people and what youth workers do and what nurses do. And we've changed the questions over the last 20 years to kind of reflect that. When we first started doing the surveys in 1999, people just did tick box surveys, and we had this really super savvy computer hacking dude in our team who said, why don't we try doing this online? And now this is really commonplace now, but it wasn't back in the 90s. So we developed one of the first MKC surveys, and the top photo is of young people, and so we had these laptops, we had these huge trunks of laptops, we had headphones, and so we asked young people questions, and we did it in Te Reo Māori and Māori language, and we also did it in English, and it read the questions out to young people. So it really improved for understandability for young people who had English as a second language, and for young people whose reading and comprehension wasn't that great. Over the years, our technology's got better. We've got better at coding, and so now we use internet tablets. That was kind of the progression. We ask a whole range of questions about young people's lives. So what happens in their homes, what happens in their schools, what happens in their own personal lives as well. It's an anonymous survey, and so young people can be as honest as they can be. So this is just a quick slide to sort of say, actually, we've done these surveys in high schools at 4 time points now. We also collected school climates data so that we could kind of survey the schools around their school policies, what groups they had, what sort of health services they had as supplementary data. We also surveyed young people in alternative education, teen parent units, or young people not employed or training or education or unemployed NEETs. So I'm going to flip straight into mental health. This is for the total population of New Zealand's young people. So this is the last wave of the surveys, and I want to draw your attention to, this is using the Reynolds Adolescent Depression Scale. And so what we've done is that we've asked young people over the years about their depressive symptoms. And what you will notice in the yellow bar graph is that there has been really quite a dramatic increase in young people reporting depressive symptoms. particularly amongst our females who've been fairly consistent, and our males. If we look at this for suicide attempts, and New Zealand has one of the highest youth suicide rates in the OECD. And when we look at some of these results, you can kind of see, this is actually 7% of females in the last 12 months in high schools in New Zealand have made a suicide attempt, and 5% of males. If we look at the deprivation, so these are measures of socioeconomic deprivation, we can see there is a really strong gradient there associated with poverty. So, our kids who experience poverty are much more likely to have made a suicide attempt. Now, if we look at this data for Māori, we can see here that there are similar trends. So I think the first thing is to note that most young people don't have serious symptoms of depressive symptoms, but what we can see is that we are seeing a similar trend, and actually a much bigger trend. 39% of Māori young women have got serious symptoms of depression that would suggest that they need some sort of intervention, and 19% of Māori young men. And this is, 12 to 18-year-olds. If we look at inequity, and what you can see in the left graph is that kind of between 2007 and 2012, we saw a little bit of a narrowing of the inequity in depressive symptoms for Māori. But then again, between 2012 and 2019, we saw a really dramatic widening. So while we've got really high levels of depressive symptoms for youth across the board, the gap is really widening for Māori young people, particularly our females, our young women. If we look at this again for suicide attempts, unsurprisingly, when we look at the depressive symptoms, there are increases in suicide attempts between 2012 and 2019. Now, this is really concerning because since COVID, we've seen a real increase in young people's distress, anxiety, and mental health. So this is even pre-COVID. If we look at suicide attempts, once again, you'll see it in the graph on the left-hand side that actually there is once again a widening of the suicide attempts inequity. Important slide. And I'll just walk you through this a little bit. So if we first of all start with good well-being in the green, what this kind of talks about is that if you are non-rainbow or non-LGBTQI plus young people, and you have a 73% chance of having good well-being, and that's using WHO well-being score. If you are a white rainbow young person, it goes down to 38%. If you're a non-rainbow, so if you are non-LGBTQI Māori, you have 70% well-being, but actually if you are Māori and you have rainbow, then you have poorer well-being. Interestingly here, this is one of the times when white rainbow youth have worse outcomes than Māori rainbow youth. And I do think that that's partly because of colonialism, and there is some more embracing of rainbow identities in Indigenous communities. Not always, but there is some evidence there. So then if we look at depressive symptoms, we see a similar pattern, that here being rainbow is incredibly damaging for young people's depressive symptoms and well-being, and similar again for serious suicide attempts. If we look at this for young people with a chronic illness or disability, we will see here that, if you have a chronic illness or disability, this is a significant risk factor, and really highlights the intersectionality of, what in my culture is takatapui, or same-sex attracted or transgender young people back here, and then the intersectionality between a number of the different spheres that young people live in, and how the cumulative effect of indigeneity and disability and rainbow cultures can have on mental health wellbeing for young people. If we look at rangatahi Māori is the Māori word for young people. So if we look at foregone healthcare, we can see that 27% of Māori had to forego healthcare that they needed with them in the past year, compared to 17% of Pākehā or white people. So serious inequities there. If we look at discrimination and racism in healthcare, this is a relatively new question that we've been asking. 23% of Māori young people said that they had been treated unfairly by a health professional because of their ethnicity. Not because of anything else, because of their ethnicity, and shows that we have an inherently racist system, healthcare system. Now I've shared all the bad news with you, I'm just going to share a good news slide. And one of the things that we've seen in huge improvements in over the last 20 years is substance use. So here you will see that when we first started doing the survey back in 2001, 26% of young people were weekly cigarette smoking. Now it is 5%. If you look at cannabis use weekly or more often, it's gone from 14% down to 8%. If we look at binge drinking in the last 4 weeks, it's gone from 46% down to 28%. So huge gains here for Māori rangatahi. And, I think this really highlights that when you actually put some resourcing, some public health efforts into actually addressing Māori-specific strategies around substance use, it can make a difference over time. And 20 years is a really relatively short period of time to see really dramatic changes in behaviour amongst an age group from an epidemiology perspective. I'm just going to walk you through what I call the eyeball graph. And so what I want you to first do is to notice the green dots. The green dots are positive change. And so one of the things that I think is really important is to kind of acknowledge that there have been huge gains in health outcomes over the last 20 years. So, for instance, I've just talked about substance use. We've seen nearly a 50% reduction in substance use amongst Indigenous Māori young people in New Zealand. Fabulous news. We need more of that. If we look at driving used to be the leading cause of mortality and morbidity amongst New Zealand young people. It is now no longer. We've seen huge improvements in mortality for dangerous driving, drunk driving, and all sorts of things in this age group. We've also seen really large improvements in family connectedness and school connectedness. And we know that those things are really incredibly important for young people's overall well-being. Where we have seen things decrease, which are the red areas, around things like sexual and reproductive health. So consistent contraception use and condom use, and then also our mental health area, which I've already talked about, and then also some really important worsening of access to healthcare. So, people are trying really hard to improve healthcare, but we are doing worse in that space, and also witnessing violence. So the green refers to things improving, the red refers to things that have gotten worse. Overwhelmingly, Māori youth are doing so much better, but there are some really key areas here that we've neglected in terms of our policy and programs, and it's showing in our statistics. So overall, in summary, really huge positive changes for rangatahi Māori in New Zealand. some really concerning mental health trends. And when we've looked at this internationally, this is a really concerning international trend around young people's mental health. There are considerable and growing inequity for some issues for rangatahi Māori. But what this shows is that over time, if we resource specific areas with cultural lens, with Indigenous services, and have the political will to support that, we can make really huge gains for Indigenous peoples. And so for more information, check us out online, tweet, email, whatever. So, no reira, tēnā koutou, tēnā tātou katoa.
Good day. My name is Eugenia Flores Melander, and I am an associate professor at the College of Nursing at FSU. I'm also the co-founding director and associate director for the Center for Population Sciences and Health Equity, also at College of Nursing at FSU. I am so happy to be here, happy to have been considered among these wonderful leaders, and I cannot be with a best and excellent group of exciting, intelligent, fun-loving individuals. So happy to be here with everyone. As we all have explained the importance of acknowledging our land, I want to take time not only to acknowledge those that have been before us, but also those who will come after us. And that's how we are creating a legacy and a history. So I also acknowledge all Native Americans, Indigenous people, and communities who have been or have been a part of these lands and territories throughout Mother Earth. I cannot say that I will be here without people like Dr. John Lowe, obviously Dr. Odette Bass, Dr. Faye Gary. I have had wonderful mentors, and those mentors have come in my life because of the MFP program. So my presentation may be a little bit more of my history, because I don't think that we have always understood that this path that we take is easy, and also how the different individuals in our life have contributed to it and motivate us in our support system. So I do want to acknowledge that and give time to really represent that here, because it may be just because I just got back from Panama and I'm just so humbled to be where I am. And my heart is just full of love. And I want to share how I have come to this moment where I am right now. And part of the reason why I am doing the research that I'm doing is because of who I am, and who I am has been part of where I have been, right? We all come from different places, and we have to utilize those little pieces that have developed who we are. So I am definitely an immigrant to this country. I spoke nothing but first my native language, we have lost now, because then I had to learn Spanish, and now I have learned English fluently. I have been a daughter to a mom who has come from another country to develop who she is and develop who I am, but she has also struggled with a history of domestic violence and has had 4 children and raised them individually pretty much all by herself. She did obviously have a support system, but she's really who I have admired for all of my life. I have developed a sense of who I am because of the people who have been there before me. And now that I am, I want to say, a little younger than Dr. Lowe, and I won't tell my age, I appreciate the little things that have happened throughout my life and that have placed me in a place of going back to my own country and my own peoples to make a difference. So all those things actually give me the diversity of thought, and then gives me the ability to develop solutions to provide health disparities specifically for my people, from the voice of my people. So I wanted to start by saying that, because those are the things that we have to take into heart when we develop our research, our teaching, and our practice. You cannot have other individuals tell you what is important to you. And I have to say, and Janet Jackson will acknowledge this, because she has been with me from the very, very beginning, holding my hand all the way till now. And one thing that one of my mentors told me was that I should not only research what I want to research for my people, but I should also be able to provide some kind of services when I go into my communities. And that is why I became a psych mental health nurse practitioner. I wasn't one when I first started this process. I was an acute care, critical care, open heart surgery nurse in the floor. But again, I always wanted to study mental health from my own family history. and I wanted to make a difference. But at the same time, I cannot make a difference if I cannot support and help where it's needed most in my community. So with that said, that's how I became a mental health psych nurse practitioner, and also I started to research mental health, more specifically cumulative trauma. So I'll talk a little bit about cumulative trauma, which now we are all seeing more and more. It's really all about the different things that an individual has experienced throughout their whole life and impacts who they are right now at the moment, right? We cannot say that, for example, myself, that migrating from a country and leaving my family behind has not impacted who I am today, has not impacted my health. The same thing as if you have experiences, adverse childhood experiences, those things impact you as an adult. So when I talk about my culture, I make sure that I integrate it into my practice. I do have my own private telehealth practice that I have had now for almost 5 years. And that practice, what I call is a concierge VIP type of services for the most underserved vulnerable populations. Those are individuals who are homeless, individuals that are recently out of prison and out of jail, individuals that have no insurance, no way to provide to get that quality, very curtailed in mental health services than some people who have the resources were able to get. So I wanted to make sure I develop a program, not only for individuals in nursing to be able to replicate in the future, but also in my research and my teaching. So I make sure I give voice to the community by everything that I do. The only way that I'm able to do all the work, and I'm sure that all the panelists as well, is because you have to have a passion that is the central focus of everything that you completely do. That is practice, that is teaching, and that is research. And for me, it's obviously giving voice to the community and the mostly underserved individuals. So with that said, my first job as an assistant professor was to develop and founded a community health center. With this center, again, given the experience that I had as a psychic mental health nurse practitioner, I knew that it was extremely important to integrate mental health within primary care services. How are you going to ask somebody to go to two different sites to get two different services and pay two different fees? So if you're truly trying to provide services and research and teaching to a specific population, you have to hear what is it that matters most to them. Not what matters to you, not what matters to your research or to your teaching, but what matters most to them. And with that, I was able to found this center, which now I understand they have received the FQAC lookalike status, which is a big deal for sustainability purposes, and eventually become a completely FQAC center in the future. So again, this is just part of the vision that has been possible because of the MFP program, because of the many different supports that I have had received and mentors, more importantly. So with that, as I mentioned, I started my dissertation with looking at cumulative trauma. And that cumulative trauma, as I have studied, has evolved to look at the different types of traumas in sections to see how it impacts individual. Here I'm talking about different realms of ACEs, right? And here, as I mentioned, number one, we're talking about household. How does an individual's family living in homelessness impacts their childhood, divorce, preventive mental health, alcoholism, and drug abuse? I could tell you firsthand that up to this day, I still have PTSD. If I experience certain triggers, it brings that moment right back to life, even if it happened 35 years ago. Emotional and sexual abuse, domestic violence. So we have to take into account the household experience that individuals have had throughout their lives. Then you look at community, which we look over here, we look at number two, poverty. That's when you talk about environmental stresses, right? Bullying, substandard wages for individual to work or not be able to provide for their family, the lack of jobs, securities, discrimination and racism, a major important things that we always have overlooked, but thankfully is a major part of conversations today. Hopefully it will come out now with some actions. The lack of social capability and mobility for certain individuals in certain neighborhoods. And number three, obviously, as I mentioned, environment, things like, COVID, lack of resources, earthquake, tornadoes, earthquake in Florida, as I live, the wildfires, the climate crisis, how all those things combine impacts the individual and the family. So I have been working in this environment, how those things impact somebody's mental health, but not only that, but the cardiovascular system, more specifically blood pressure risk. So as I have continued on, I have developed different and have added different expertise. And most recently, I am adding epigenetics to my research because I realized that you could develop as many interventions as you want, but are those interventions truly doing what they're supposed to be doing? So you don't transfer these markers to the next generation, right? So if we have lived with a history of trauma, we're passing those markers to the next generation. And how can we prevent that? So the only way to really see that is by doing some epigenetic studies. And more specifically, I will be focusing on DNA methylation, which is something that is really impacted by the environment. So you're not talking about changing the genes. You are really talking about turning that gene off or off based on the environmental stressors the individual has experienced throughout their lives. So this is my next project that I've been working on. And again, I have another mentor who I will be bringing home as well. And I'll talk a little bit about how this collaboration has come throughout the different years. This is a wonderful map of Panama. Panama is the isthmus of the world, meaning that this is the most narrow, smallest part of the world where it connects the Pacific Ocean to the Atlantic Ocean. And the little thing that says Colón is circle in red is where I was born. Dr. Bass and Dr. Lowe could tell you that, let me tell you, this is not one of the nicest places to live, but that is home to me. It has not been properly supported by, again, governmental for different reasons. But my tribe is Kunayala, and we have a small land tribe in Colón, but most of our population is really reside in different islands outside Panama City. We do not follow any of the Panamanian rules. We have our own separate government, our separate culture. And this is the background that you're seeing. Is what we call molas. We have created this by hand for centuries and centuries. This is how we initially were able to trade for food and things that we needed to survive. So with, again, the Europeans, they bought things, mostly bad things. We were able to trade in order to get food because we were not able to get that back in the days. So with that said, I don't want to just be biased to my tribe. We have 7 tribes in Panama, and they have different locations and tribal territories in Panama. So Panama, I want to say right now, we have a total of 7 tribes for counting for 15% of the population. Most of the Panamanian population are mestizos, it's about 60%. So we have very little Caucasians, whites in Panama, and mostly those whites are Europeans that have obviously come from, the centuries of invading Panama and the native group in Panama. So this is me in what I call my family's island de León, de Tigre. I have to say that my family of Flores, which is my father's name, has a long legacy. And even now, my uncle is continuing to maintain that legacy. He used to be the Minister of Health for Colón, and he's definitely the one who's helping me integrate research back home, and specifically in our tribal area. So here, this is the wonderful people who I have been able to learn from them. So Dr. John Lowe obviously was my dissertation chair and has been in my life as long as I have been alive, right? About 15 years, Dr. Lowe. And he has been able to grow my ideas. And then not only that, but then introduce me to wonderful people like Dr. Bess. And we were able to travel to Australia. I was able to see the different barriers and solutions that are happening in Australia. And we're able to share ideas and also see similarities and differences. And there's not so much differences when it comes down to Indigenous groups throughout the world. And that's what is so amazing. So that's my husband, and he was like the hit in Australia. I had to fight to keep him, next to me because he was like a hider. But again, he is my partner in crime. But one thing that you have to do when you create these wonderful groups is you surround yourself with individuals that have the same kind of passion for you, for the same population, and they help you grow, but they also challenge you to continue the work. You're not doing this by yourself. You cannot do a good job for the community by yourself. So make sure you surround yourself by great people that will continue to challenge you and will also support you, and vice versa. And that's it for me. Thank you so much. Make sure you live every moment and you laugh every day and you love beyond words. Thank you so much.
Hi, everyone. Thank you for coming. My name is Amy Lee. I just graduated with my master's in nursing, and I will be moderating this session. And the panel will be answering questions regarding achieving health equity among Indigenous groups through nurse-led Indigenous research. And our four panelists today are Dr. John Lowe, who is a Joseph Blade Centennial Memorial Professor in nursing at the University of Texas at the Austin School of Nursing, as well as faculty affiliate at the Native American and Indigenous Studies at UT Austin College of Liberal Arts. We also have Odette Best, who is Professor of Nursing and Associate Head of Indigenous Research and Community Engagement at the University of Southern Queensland in Australia. TC, or Terry Ann Clark, who is Associate Professor at the University of Auckland School of Nursing in New Zealand. And Dr. Eugenia Millender, who may not be able to join us today for the session. And she is co-founder and Associate Director of the Center for Population Sciences and Health Equity and Associate Professor at Florida State University. And since this is just a small tidbit of their careers, we encourage you to read more about our speakers' accomplishments on their bios, which can be found in your briefcase. And thank you, panelists, for this wonderful presentation. And we will pivot to the Q&A session. Let's see if we have any questions in chat, or if you do not type it in chat, feel free to speak up to ask any questions to our panelists.
Hello, my name is April, and I'm in San Antonio, Texas, so not too far from the UT Austin panelists. Hi. Anyway, my question is, how would you say we can better help our patients, or would we do anything different as far as helping patients who are of Native American background with an alcohol or drug addiction? That's my specialty, is alcohol, is, substance abuse and addiction. That's where I have my certification in, and that's where I have a true love. So just want to throw that question out there.
Since that's my area of work, I'll go ahead and speak to that. And thank you for the question. It's a real honor again to be here. And also, I failed to mention during my talk that I am an MFP alum and also have served as the National Advisory Committee Chair. So the MFP is family to me, and it's a wonderful program. And so it's always good to feel like I'm back with family. I think there are so many concepts around addressing substance use with Native populations, and it's always become a stereotypical, concept, that all Native people, especially in the US, have this issue. And I would say that that's not true. Number one, that is not true, because I grew up in a family where there were those issues, but also I grew up with a father who never went to school because he was Native, and there were no options, and he never, not grade 1, etc. But he lived very traditionally in our community, and he lived by our traditions and culture. And I have learned that probably having that opportunity versus having to go to a mission school, a boarding school, a residential school, and have the culture really stripped from him, that really is what created a different path and a journey for his life. And so our approach is, again, with youth, and we take a strength-based approach. You know, so many of these programs that are available to Native people are based on non-strengths. It's all about the behaviors and how bad they are. And so, and then therefore, engaging in that behavior, then therefore you are bad. And that's what our people have heard all their lives. You're just bad people, you know? So we take a very different approach, and our approach is that our culture is very valuable, has contributed to the human family throughout the world. All Indigenous people have, in a great way, but it's never been recognized, and it's never been valued. And so it's about reaching in, and I think with Native people, and really reaching deep that they are sacred beings because they were created by a sacred being, and they have a being that is, we're not going to focus on the doing, and because the doing doesn't dictate the being being dictates the doing for Native and Indigenous people. And so therefore we really focus on the being. And we know, we acknowledge, number one, we acknowledge the pain and we acknowledge the victimization, but we don't stay there. And we want to move beyond it, because if you stay there in that victimization and in that negativity, then that's what controls you. And so, but it has to be acknowledged. It does have to be, the truth has to be acknowledged, because reconciliation without truth can't happen. Thank you for the question.
Thank you for the answer. Appreciate you.
I just want to say a similar approach in New Zealand. And, you know, rather than saying what's wrong with you, it's like I often say, well, what's right with you? What are your superpowers? And so when working with young people, really kind of identifying the things that really keep them strong, the things that are really positive, and utilizing them as a strategy for you know, strengthening and supporting. So
Thank you for sharing. That was very informative. We have another question in chat by Marlene to Odette. What theory do you use for your historical analysis?
Thank you very much for the question. I have started to engage with a lot of Indigenous standpoint theory. And Indigenous standpoint theory here in Australia was really commenced by Aileen Morton Robinson, who is a Kondamuka woman and actually comes from Stradbroke Island as well. So she's got intimate ties to Straddy or Minjerribah. So her work is absolutely phenomenal, and her seminal work was Talking Up to the White Woman. So she looked at unpacking white feminist theory. She did an amazing job. So her old theorising was around Indigenous standpoint theory. So I used that. I also used Karen Martin's work, which is also another Indigenous woman from Minjerribah again. Undisputably, us Minjerribah women, we love our academy and our work. And she does a whole theorising around Indigenous standpoint theory on knock before you enter, really talking back to how historical research has occurred amongst Indigenous people and how it's problematic and why it is problematic. So it's also about sovereignty for us as Indigenous people, sovereignty for us as women who are sovereign. The other standpoint, Indigenous standpoint theorist that I do engage with, not as much, but I do a little bit, is Martin Nakatar, and he's a Torres Strait Islander man. So he talks very much around Indigenous standpoint theory from a Torres Strait Islander perspective, which is, you know, essentially the other Indigenous population in Australia. So I hope that has helped. Thank you for the question.
Thank you. That was very enlightening. I think we have time for one or two more questions. I got a question from Elizabeth for TC. what led to the improved health outcomes from 2001 to 2019 among the Maoris. I apologize if I pronounced that incorrectly.
Oh, look, I think there was a lot of work going in. You know, we had a Liberal government. During that time period, there was a lot of work going into prevention activities, a lot of work happening in public health policy. I think that, you know, all the stuff we know in public health was being implemented and still is being implemented. So, you know, what I think the key lessons there are is that if we resource, if we put evidence into place, we will see a corresponding improvement in well-being. I think the fact that we were using lots of culturally informed strategies really helped too, that we were had really specific targeting for young Māori around what they saw, how they saw the world. It wasn't deficits focused, as John J. Lowe has talked about. It talked about what were the things that keep us strong and keep us proud and make us proud to be Māori. And I think that's one thing that a lot of people do, is that they talk about what you shouldn't be doing and how bad it is for you, where actually we should be talking about what, flipping it around and kind of going, actually, well, what is there to live for? And how, how do we give young people other options that aren't around substance use and, activities that can be really damaging to their well-being.
Thank you. Seems like you've done a lot of work surrounding that area. We only have about 2 minutes left in the session. I apologize, Lynette, for not being able to get to your question, but I think we'll have to wrap things up. But thank you so much, panelists, for sharing your inspiring wisdom and work. And finally, thank you to the participants for joining us and for the thoughtful questions that you asked.
That's all right, Amy. Thank you.
Bye, everyone.
Fantastic.